So I'm going to turn now to take you through these new guidelines that we have and emphasize some of the aspects of them that I think are quite important, and also to show you some of the underpinning evidence base contributing to the new guideline. So the first thing is the guideline gives a very clear stratification of definitions of which groups of people have very high risk, and moderate risk for subsequent cardiovascular disease. And those deemed to be at high risk include patients with diabetes and established cardiovascular disease, or having other target organ damage, such as microvascular disease, or having 3 or 4 major risk factors. And they also include in the very high risk category very early onset type 1 diabetes of long duration of at least 20 years. Okay, that's a substantial proportion of the type 1 population. They deem at high risk to be patients with diabetes duration of at least 10 years without target organ damage, so no microvascular disease, plus any other additional risk factor. And then those at moderate risk are young people with type 1 diabetes aged less than 35 or having type 2 diabetes below age 50 with a diabetes duration of less than 10 years without other risk factors. So in the clinic, the vast majority of your patients with diabetes are going to be in this category, one of these two categories. The new guideline states very clearly that the target LDL cholesterol should be, in those with very high risk, that you achieve an LDL cholesterol of less than 55 milligrams per deciliter, that's 1.4 millimoles per litre, and achieve a 50% reduction in your LDL-C. And for those at high risk, the target is 70 and a 50% reduction in LDL-C. So getting below 70 for those at high risk, getting below 55 for those at very high risk, and getting below 100 in the group deemed to be at moderate risk, less than 2.6 millimoles per litre. The guidelines also state that in people with type 2 diabetes at very high risk, an LDL-C target of less than 1.4 millimoles and a reduction in LDL-C of at least 50% is recommended. And importantly, for that, they give a 1B classification of the evidence. And in people with type 2 diabetes, a secondary goal of a non-HDL-C target of less than 2.2 millimoles per litre in very high risk cardiovascular disease patients, and less than 2.6 millimoles per litre in high cardiovascular disease risk patients is recommended. And that's also given an evidence category of 1B. So turning now to the evidence-based statements for the use of lipid-lowering therapies. First thing is that statins are recommended as the first choice, continue to be recommended as the first choice lipid-lowering treatment in people with diabetes with high LDL cholesterol levels. And administration of statins is defined based on the cardiovascular risk profile, and they've already given the clear strata definitions of the different levels of risk. The guidelines are clear that if target LDL cholesterol is not achieved, then combination therapy with ezetimibe should be the next step. And then in patients at very high risk with persistent high LDL-C treatment, despite treatment with a maximum tolerated statin dose, in combination with ezetimibe, or in people with statin intolerance, a PCSK9 inhibitor is recommended. And very good to see that this has been given a 1A evidence base. So those of you that chose that option on the opening slide got it right. I think that was 43%. So that's good.